From the last presentation, where I had started off by talking about 5 functional components of the mandible. Apparently I didn't point out the 5th one, which is really the coronoid process, which serves for the attachment of the temporalis muscle, one of the elevators. So that was a question that I got from 2 or 3 different students. Were there any other questions about
Can you just name the 5 real fast then, so we have it?
Sure, yeah. Certainly the coronoid process, like I just said, the condylar process, the ramus itself, the corpus of the mandible, and the corpus obviously hosts or holds the alveolar segment, so that would be the 5th.
Thank you.
You're welcome. Corpus, and the alveolar segment, which is the tooth-bearing part of the mandible. So the last topic that I'm going to cover with you guys is really about condylar growth. And it's going to be difficult to talk about condylar growth without really talking about the TM joint in its entirety. So I will spend some time talking about the joint as well. So the objective is obviously to go over condylar growth in itself, but as you have noticed, I try to bring in some clinically relevant pieces because to me that's the easiest way to remember things. The importance of the condyle, I mean, obviously there are several different joints in the body, but the most important ones as dentists or craniofacial practitioners is really knowing the bilateral joints, the temporomandibular joints on either side. And perhaps its greatest function is actually in allowing the articulation of the mandible to the actual cranial base. And that's why you can actually move the mandible, because of that articulation that the mandible has, or the condyle has, with the basic cranium. But it obviously does serve some other roles. As a result of its articulation here in the glenoid fossa, it actually plays a major role in establishing occlusion. And then as we're going to talk about, as it relates to growth, the condylar area plays a very, very important role. It used to be believed, in fact, that this condyle was the primary growth site, that it could drive the growth of the mandible. Today, I think the consensus is that that's not necessarily correct. It is more of a secondary cartilage. It plays a secondary role in the adaptation and in the endochondral formation, which results in the downward displacement of the mandible and the growth of the condylar segment. So like I said, it establishes a movable articulation with the cranial base, which determines the occlusion to some extent. Obviously, there are other factors that go into establishing occlusion, so it's not the sole contributor in such an area. And this is what I meant when we talked about growth site, which, you know, I put it in parentheses for a reason. Because I don't think today anybody would really hang their hat on it and say that it is the primary growth site. Today, I think the consensus, like I said, is it's more of a secondary area. Now, why is this area different than perhaps the rest of the mandible? After all, a large portion of the mandible is actually formed by intramembranous bone formation. Yet this area of the mandible is actually formed by endochondral bone formation. And I will go back to a slide that I showed you in the last class. But remember that there is a superior aspect of the condyle, which is almost an avascular area. And then there are different layers within the condyle itself. We'll get into that medullary area. But what happens is you have this non-vascular area which is able to respond to compressive forces. Remember, periosteum will respond to a compressive force actually by resorption. Cartilage, on the other hand, is capable of remodeling. So it can withstand this pressure because of its very turgid type of matrix that it has, which can actually imbibe a lot of water into it. And so that's how the cartilage is actually able to adapt to the pressure. So this is essentially the condyle, and we talked about this last time too with the medullary core. I know there was some questions, or some comments I got about this as well, and all of you were spot on, so I'm not going to spend a lot of time. But you have that external, you know, the capsular layer that you see here, with the pre-chondroblastic layer, which is very, very active in cell formation there. Angela, do you need something?
one person really quickly.
Go ahead.
I'm so very, very sorry. Just 1 second, please. Thank you.
I was hoping it would be me.
Sorry, not this time. Maybe next time.
So what you're looking at is a very cell-rich zone in here, followed by a chondroblast layer, which is represented by C, and then you have the part down here, which is where you find the endochondral bone formation. And as you all very well know, the growth of the condyle is taking place posterior superiorly, which ultimately results in the downward and forward displacement of the entire mandibular complex. These areas are actually cortical bone, and they undergo your traditional periosteal and endosteal remodeling, where you have intramembranous bone formation. I just asked one of your colleagues and classmates who helped me actually get some chalk how critical it would be to actually talk about the structure of the joint itself. And he assured me that most of it has been covered in your gross anatomy class. So fortunately for you, I will not be drawing on the board because I'm not the greatest artist. But what you're looking at here is essentially only a portion, obviously, of the temporomandibular joint. There are various different components in here. What is found right above the condyle? Sorry?
Articular disc.
The articular disc. Why is that so critical?
It keeps like bone to bone contact.
Exactly. A joint cannot really function with bone-to-bone contact. That's why whether it's in the shoulder, whether it's in your knee, whether it's in your elbow, you typically have cartilage right between the two. And so that cartilage plays a very, very important role in allowing for the motion that we talk about. It also absorbs a large amount of the pressure when you're chewing, when you're talking, when you're actually moving the mandible. Right between the cartilage and your actual condyle, there is a tiny space. Now, it's not true space. These are actually connective tissues. Does anybody know what that space is called? So right above the condyle, and before you get to the articular disc or the meniscus, there's a tiny space there. It's not actual vacuum, it's connective tissue there. Anybody familiar with that space? It's called the inferior joint space. And what do you have above the articular disc?
Superior display.
A superior joint space. And what's above the superior joint space? The glenoid fossa, right? Part of the temporal bone. So you actually have the glenoid fossa sitting up here with the cartilage in between, separated by a superior joint space and an inferior joint space. Now this cartilage that you call the articular disc or the meniscus is actually then attached to the condyle by virtue of your capsular ligaments, which takes insertions from the superior head of the lateral pterygoid. So why is all this important? Can. The key in this is when you are opening and closing your mouth, when you're talking, you're yawning, you're eating, you're swallowing, you essentially have two movements, right? There's rotation and translation. And that's a really, really important part for you, because clinically, when you are presented with a patient who has a TM joint disorder, commonly called TMD, I hate it when people, especially healthcare practitioners, when they come in and say, I think I have TMJ. Guess what? Everybody's got two of them, right? What they really mean is TMD. TMD is a disorder of the temporomandibular joint. But when you're trying to diagnose it, these two become really important in being able to establish whether the person can rotate and translate, or is only capable of rotation and is unable to translate. Are you familiar with these terms? Have they gone over it? And they have?
Yeah.
Okay, good. Which class did they go over that in?
Masseter dynamics.
And that's taught by Roma or?
Yes.
Okay. Yeah, I just want to make sure that I know who was covered what. Why, what's wrong? Oh, Dr. J? Yeah. All right, so then you're familiar with the inferior joint space, superior joint space. How much does a person rotate before they go into translation? You covered that?
Oh, 20 millimeters.
Very good, that's right. So if a person opens 20 millimeters and is unable to open further, what's likely the problem? Something is preventing it from translating, right? And it's probably that the disc is displaced. So that's how you will start using this clinically. Or for example, a person opens and they deflect to one side. Person opens, they open about 20 millimeters just fine, and then they deflect to the right side. You're going to have to put your thinking hat on to realize where the displacement actually is. So that's the importance in actually knowing about your articular disc and whether the superior joint space or the inferior joint space is affected. As far as growth of the condyle goes, like I told you, this medullary core is where most of the endochondral bone formation is taking place. Obviously, the attachments of the superior head and lateral pterygoid into the neck of the condyle continues to affect the remodeling that takes place in that segment. So I didn't want to get into the drawings and all that because it's obvious to me that you guys have covered that. From a clinical standpoint then, remember how we talked about in the maxilla? You can actually make some fairly dramatic changes. Whether it was widening of the maxilla, whether it was remodeling posteriorly, trying to control the growth of the mandible, oh, the maxilla, sorry. I think you saw some fairly major changes that can be made. What about with the mandible and specifically the condyle? And secondly, I think, as we just talked about, in terms of your TM joint disorders, it becomes really important for you to understand the structure, function, and growth of the joint. So let's take a quick look at it. Can we actually grow the mandible? No. It's been controversial. I think it would be fair to say that there was work done in Europe. It started actually in the 1930s, where they tried to actually position the mandible anteriorly or forward, try to mimic growth. And they hoped that the condyle would actually remodel to suit that newfound position. By the 1960s, there was some data actually coming out suggesting that maybe you could make a difference. By the 1980s, that information had hit the shores of the United States. And it became very popular where people believed that we could actually make changes or grow the mandible. I think about 10 years ago now, there were some very good randomized clinical trials that were done that actually demonstrated it may not be quite as efficacious as we once believed. In other words, you might be able to make a difference on some, but it's certainly not predictable in terms of your ability to grow the mandible. So let's take a look at a patient like this. Tell me what is most obvious. What's that?
To the side.
There's an asymmetry, right? We don't know if it's a shift. We don't know if one condyle is bigger than the other. You don't know what the actual underlying etiology is, but it's obvious there's an asymmetry. And in an asymmetry like this, the first thing you want to do is to take a look and see what's going on with the dentition. At least as an orthodontist, that's one thing. I mean, Brian Williams, I'm sure you're all familiar with the name. He's in the news all the time now for having overestimated his role in certain things. But the most captivating thing about him is his facial asymmetry. He's got a huge mandibular asymmetry to his left. I know some of you are probably Googling him right now. Brian Williams, was the news anchor. He's got a massive mandibular asymmetry. I always wondered, is he a crossbite on that side? Did the dentition compensate? Wish he would just let us do a genioplasty. But anyway, so here is a situation where she actually does have a crossbite on that side. Again, we really can't tell based on a photograph whether in fact the mandible is deflected to that side, whether the dentition has caused it, is one joint smaller than the other, is one corpus length shorter than this one. Very difficult to pick up on a clinical photograph. You could take a CT and study it. But my job in this case was to try and figure out, can I fix it? In other words, can I actually get this condyle to move the mandible over? In other words, can I actually modify the growth of the mandible? Consistent with what you would expect, there is a mandibular asymmetry to that side, midlines are off, so I go ahead and before I can actually rotate the mandible or do any kind of mandibular modification, what do I need to do? I've got to first get my central incisors in the right position. I've got to get the incisors in the right place in the face before I try and adapt the mandible to it. So I go to the literature, I make sure that what I'm doing is reasonable, and it does say that people who have unilateral crossbites like that are predisposed to an asymmetry, and that you should address it. So I go ahead and I actually line up the incisors. So her upper incisors are now in the right position. Now I'm going to have to figure out a way to try and manipulate mandibular position, also condylar position, to see if I can get the condyle to remodel the way I want it to. So I create a couple of dots, one in the middle of the forehead, the other I actually use in the middle of the symphysis. I don't look at the dentition. And I have her bite into a wax bite in the newfound position. Now I'm going to fabricate an appliance that when she wears it, it's actually going to rotate her mandible to that side. And this is what the appliance looks like. It's a very simple device, not very complicated. And all it does is, it overcorrects the mandibular position. You can see that I've actually moved the mandible over. It was off by about 3. Now it's off this way by about 3. So it's about a 6 millimeter rotation of the mandible. And I have Kelsey wear this now for the next year, as she's still growing. Now again, remember, on an adult, this would not work. This is the change that I get, and this is where she finishes up after her orthodontic treatment. So did we really correct this asymmetry? Did we really correct it skeletally?
No.
If you look at a photograph,
Your chin is looking like that.
it looks, no, you're absolutely right.
Yeah.
You're absolutely right. So if you take a look at her in smile, because the midlines are coincident, it can be a little deceiving. But take a look at her with her lips closed. She's still off to that side. So this would be an example of where I don't believe, now till I actually look at x-rays and actually do the comparative analysis, there's no way to really tell. But it doesn't look, from the surface of it, like I was actually able to get everything that I wanted. Maybe part of the way, but not all the way. And the occlusion is fine. Okay. Any questions about that? Yes?
So where was the change from your appliance? Like what?
We got some dental changes for sure, because I mean obviously we corrected the asymmetry dentally.
Yeah, but after that?
I don't think we got as much skeletal change as we had hoped. And I think today most people will tell you that unlike the maxilla, which is more amenable to a clinician's insult, if you will, it'll allow you to mold the maxilla. You can change the maxilla in different planes of space. I think today the consensus would be, at least I believe, that the mandible is a lot more under genetic control than the maxilla is. The issue is that not everybody has the same amount of genetic input and the same amount of environmental input. In other words, everything that you see here in yourself or in the person sitting next to you, whether it's their temper or whatever it might be, it's always a culmination of those two factors, right? The genetic background superimposed with it, the environmental basis. And I don't think anybody has really been able to figure out how much genetic contribution goes into your mandible versus yours versus yours. So for example, a person who has this huge environmental insult, take a child who's growing up with a thumb-sucking habit. You remove the insult, that changes things. So in these situations, it becomes very tricky to actually try and figure out. And unfortunately, in the absence of compelling scientific evidence, guess what happens? You end up trying. But it's not predictable.
So, sorry, just so the girl, did her condyle change, like the growth of it?
It's a good question, and that's why I said, unless I actually got post-CTs, checked for remodeling, actually evaluated it, very difficult to tell.
Okay. But like initially when she had the issue, when you looked at her condyles, it wasn't like it was like lopsided.
And actually the imaging that we used at that time, and that was a case I treated maybe 8 years ago, the imaging that I used at the time was not even sophisticated enough for me to look at that. Today I could. Any other questions about that? Okay. How about trying to control mandibular growth? How about on a person like this, where you feel that there's an element of mandibular prognathia? The terms prognathia and retrognathia are essentially, retro is behind, pro is ahead. I see some of you shaking your heads like, you know what, we know all that stuff. I'm sorry if it's redundant. I just don't know where you're at with some terms, that's all. But in a profile like this, you can make a decision. Are you going to try, here's an 11-year-old girl. We do know that the mandible tends to outgrow the maxilla at a rate of 2 to 1 from the age of about 8 years till about puberty. So at this point, her mandibular growth is outgrowing the maxilla by about 2 to 1. So the question becomes, are you going to try something to actually curb the growth of the mandible? Is there something that you can use here till she's at least post-pubertal to apply pressure on the mandible in the chin area, in the symphysis area, to try and put pressure on the condyle and prevent growth? And so that was an attempt that was made. All the way from the 70s, there's been discussion about using what is called a chin cup. And a chin cup is essentially an acrylic or a plastic device that attaches to the chin and uses the base, the back of the head, the occipital bone, essentially, to apply pressure against the chin. The concept there is exactly that. Can we actually control the position of the chin? So here's the person, as you would expect to see in a person with a prognathic mandible. You have what? Posterior class 3 occlusion. You have cross bites. Part of the cross bites can be because a wider part of the mandible has now come forward and is an approximation with a narrower part of the maxilla. So if you guys move your mandible further forward, just go ahead and go into protrusion. You basically brought a wider part of the mandible into approximation with a narrower part of the maxilla and induced a crossbite. So in class 3s, it's not unusual to have that kind of posterior occlusion, and she has a complete anterior crossbite, as you would expect. Now you can take the route that I'm not going to do anything because I cannot control the growth of the mandible. But then if you want to fix this post-pubertal, and you know it's only getting worse, you're going to have very few choices. And I'm not nervous about pulling the trigger on surgery, but that would become a legitimate choice in terms of having to either set the lower jaw back or bring the upper jaw forward. And as you will learn over the course of the next 3.5 years, it's a fairly invasive procedure. So the question becomes, if this is your little sister or your cousin, are you going to just say, well, wait? Or are you going to say, I'm going to try something? And this is the issue with trying to predict mandibular growth. So here's the person with the anterior crossbite, and this is the device that you typically use. A posterior superior directing vector applying a fair amount of force in that posterior superior plane of space, trying to prevent downward and forward displacement of the mandible. Here she is. Once we had corrected her AP problems, we go ahead, put some braces on, and finish up her treatment. Again, an instance where you would have to take your radiographs, you'd have to sit down and measure it, and always the issue is this: did you really fix it, or was it partly nature fixing it on its own? Now on her, I have to confess, it was actually a combination of things. We actually did apply force on the upper jaw to bring that forward as well. But I didn't want to stress that too much because I think it can muddy the water when we're talking about the mandible. The maxilla is definitely more under operator control than the mandible is. And if I were to actually trace them out, measure them, take a look at them, my guess is I probably got the maxilla to move more than the mandible. There was a question.
How do you determine if you want to like pull one or push the other one? You know what I mean?
Correct. So I basically look at, I think I said this the first time I got a chance to speak to you. What's the most important tooth in the head? To me, it's the central incisor, right? So when I go back and I look at Bianca here, I think those upper incisors can afford to come forward. When I look at her profile here, I feel like she could afford to come forward in this nasomaxillary complex area. She's deficient in here. Her malar prominence is very deficient. And whenever I see sclera under the eye, it tells me that there may be an element of relative nasomaxillary deficiency. That's when you get that relative exophthalmia. It's not true exophthalmia. So whenever I see the sclera under the eye, I start to think about whether or not the maxilla should be mobilized. Any other questions about that?
I have a quick question. Okay.
Sure.
When you mentioned that in puberty, when the mandible outgrows the maxilla 2:1 ratio, what is the cause of? Is it just that the growth sites are more receptive earlier age in the mandible?
So that's a very good question. There are different theories about why the mandible is growing more than the maxilla, and I think I'll have to go over a couple of them. One is, remember, maxillary growth finishes earlier. Why is that? That's because the maxilla is suspended off the cranial base, and the cranial base is actually established earlier in life as well. And what I'm really alluding to is what is called, and I don't know if you've heard this term, so if you've heard it, you can just tell me to stop, the cephalocaudal growth gradient. Has anybody heard that term? Okay. So there's a term when you're studying growth and development which is called the cephalocaudal growth gradient. And here's what all that means. The ceph is the head. Caudal is basically your arms and your legs. And the growth gradient reflects or is used because the ceph forms first. And to illustrate that point, I'll take you to, have any of you seen a newborn baby? Okay. All right. How many of you have seen an infant?
Where are you people?
Yeah, seriously.
Who's gonna get out more?
When you look at a baby, or even an infant, what do you notice? Their head looks large. Why does their head look large? It looks large, it's an optical illusion, because it's the rest of the body is small. So by the time a baby is born, and these numbers I'm not 100% sure about, but the skull formation is almost 50% of where it would be at adulthood. That's because a lot of the skull formation takes place earlier on. And even within the skull, keep in mind, like I said, the cranial base is believed to fuse around the age of 6 to 8. And there's a lot of variation in this, and that's why I use the term believed. Because you can have people whose cranial base has not fused, and you can have those who have fused earlier. But as soon as the cranial base is done, the maxillary growth is inhibited. But mandibular growth is continuing. And that's why you have that relative ratio of 2 to 1. Does that make sense? Okay. So that was that. All right. And then I'm going to finish up with a dysmorphic condyle. Actually, this was a patient I just saw. Here's a person who was born without a condyle on one side. And you can see what happens. There's an obvious asymmetry entirely to that side. But the reason why I put this picture in there is I want you to look at the condition and tell me what else you find besides that asymmetry. What about the ears caught your eye? That was fantastic. Yes, there is a dysmorphia, granted.
Far inferior to what they should be.
That's exactly right. They are really, really inferiorly placed. And what's interesting about that is where's the glenoid fossa in relation to the external auditory meatus? They're pretty close. So when you take a look at him, I think that becomes really interesting. Now, he's got some other problems too, including needing to use a toothbrush, but that's... In summary, I think the couple of things that I really want to highlight for you guys as far as the joint and the condyle specifically go. Anything related to the TM joint is important to you. I'm not saying that we as academics or practitioners in craniofacial work really understand everything about the joint. There are still questions that linger. But it is a really, really important and fascinating joint to study. Knowing the structure and function obviously helps you better understand the growth. And the last part that I want to leave you with is the fact that the growth of the mandible is not under operator control the way we would wish. Any questions, any discussion about any of the cases or anything at all?
Well, I'm just curious, how did the last patient kind of chew without, like, how is that even possible?
Right. So another way of looking at that is, how does somebody chew without teeth? Anybody?
Eat soft food.
You can eat soft food. It actually alludes to the amazing adaptive capacity of the human body. I'm not saying that the pressures on one side are going to be equal to the other, but it really is amazing when you see some of these patients, how they manage. And I think that is a direct reflection of their adaptive capacity. One thing that I will tell you is I think that adaptive capacity that we're talking about is what typically differentiates, in my mind at least, a child from an adult when it comes to the TM joint. I mean, you're going to have a far larger percentage of adult patients who come to you with TM joint issues, whether it is clicking, popping, crepitus, pain, unable to open their mouth. It's far more often on adults than it is on kids. And I know in Dr. Hans's lectures, he talks about that's partly because the glenoid fossa is a lot deeper. And because the glenoid fossa is deeper, the condyle is deeper seated. And because it's deeper seated, there's less room for it to move. And I believe that conceptually. But I also think when you have a hypoplastic condyle on a young child, it contributes to the adaptive capacity that a child has over an adult. Does that make sense?
Yes.
Okay. But you don't seem to agree. You have that look like I'm not sure.
No, no, I agree.
Okay. Thanks. Any other questions? Yes.
Are these slides going to be posted online?
Yes, I need to do that. I've been awful. I know somebody else asked me last class. Might have been you. Somebody in the front row, and I haven't done it. I will get them on today. Any other questions? Well, thank you guys. It's been a pleasure.